we have a very dynamic session lined up. We have the Argentine Spine Society combined session with Association of Spine Surgeons of India. And it's my proud privilege to invite Dr. Gautam Zaveri, who's moderating this session, to take over the proceedings of this session.
We can, sir.
Yeah.
Yes.
Yeah. Good evening, ladies and gentlemen. Let me welcome all the delegates from the Association of Spinal Surgeons of India, delegates from our friends and neighbors, the Bangladeshi Spine Society, the Spine Society of Nepal, the Spine Society of Sri Lanka, the Egyptian Spine Society, the Korean Spine Society, and members from the participating associations, that is the Argentinian Spine Society and the German Spine Society. Today, we have people from all across the world who have joined us for this special session and are looking forward to the interaction between and learning from the interaction between our two societies. Let me take this opportunity to welcome our guests. You've already heard from Dr. Bernasconi, the president of the Argentinian Spine Society. Along with him, we have a very, very experienced, knowledgeable team who is going to share their knowledge, experience, and help further this program. Today, we have with them the ex-president of the Argentinian Spine Society and a very close friend of mine, Dr. Marcelo Grunberg. We have Dr. Gaston Camino, Dr. Matthias Petracci, and Dr. Juan Emmerich. All of these people are enormously experienced in the field of spine surgery. And if you look at their curriculum vitae on Google, it is seen to be believed. Just to introduce the ASSI to our people, in India, we traditionally welcome anybody with folded hands. It is called as Namaste. So let me start by wishing the Argentinian Spinal Society members a big Namaste from the entire ASSI over here. ASSI is a body which started in 1985 with 19 members. Today, it has 2,772 members. We have grown on the shoulders of these giants who have led the society over the last 35 years. Today, we have 1,000 members who have registered to see the program online and participate in the program. What are some of the activities that ASSI does? We have biannual conferences. We have a main conference which is called as the ASSICON, and half yearly we have once in a year we also have the instructional course lectures. ASSI under the leadership of Dr. Chhabra has developed an e-learning tool which will be useful for both the common man as well as to orthopedic surgeons or spine surgeons or neurosurgeons who wish to further their knowledge on spine. Over the COVID pandemic, we have been doing regular webinars. We have come out with a monthly video journal which aims to bring evidence to our clinical practice. We have launched a case discussion forum. Today, there are about 600 doctors from all across the world who are connected to us through this case discussion forum. There are 384 cases which have been fully worked up and uploaded, and there is active discussion. We have short-term and long-term fellowships, and that is something which we would like to do and share with the Argentinian Society. An opportunity for your young doctors to come to India and for ours to come there and learn from all of you. Other activities at ASSI has been doing multi-center trials. The first set of multi-center trials is just coming to fruition, and hopefully there is some exciting and new data which is going to come up and be published over the next 5 or 6 months. ASSI has a spine registry.
Janardhan.
More than about 5,000 cases are put up are on the spine registry, and it is completely worked up and actively being followed. ASSI does outreach programs where we go to second level and third level cities in India to try and spread the message of safe spine surgery across our country. A social wing is established which helps conduct free camps, not only clinical camps to examine patients or teach exercise, but also surgical camps in small villages and towns across India where patients are either not affording or are unable to access tertiary level care. We have also started in India, because of the poverty and sometimes because of the lack of access, children come to us very late with scoliosis. And therefore, to prevent this problem, we have started a scoliosis screening program which is working actively. ASSI, again, as I mentioned earlier, has multiple publications. Dr. Rajsekharan was the editor of the ASSI textbook on infections and trauma. It is still available through JP Publishers and on Amazon. 2 years ago, we came up with a series of 8 monographs on specific topics in spine surgery. These monographs were published by TM Publishers and are available again through Amazon or through the TM website. We have a biannual journal called as the Indian Spinal Journal, and we would be happy to collaborate with the Argentinian Spine Society to see if we can reciprocally get papers from Argentina to be published in this journal. If any of you from across the world are interested in following ASSI, you can follow us and join us on our website. All this information is there. All the webinars, the video journals, etc. are available as links from our website. You can also follow ASSI on our Facebook page, the Twitter handle, and we have a YouTube channel which is screening this live. Without much ado, let me welcome again all 5 members of the Argentinian Spine Society and all the delegates from across the world who are watching the program today. What is the program now? The first session is composed of lectures. We start with lectures. We intersperse between the Indian faculty and the Argentinian faculty. And thereafter, we have a very interactive case-based panel discussion, which should be exciting. And after this, at the end of this, we have a meeting or what is called as a journey with the legends. Legends of spine surgery, Dr. John Lowenstein, scoliosis surgeon from the US, Dr. Lawrence Lenke, another scoliosis surgeon who needs no introduction, and Dr. V.T. Ingalhalikar, our founder president, will all be interviewed and will be a great learning experience on various aspects of their professional and personal life, which will teach us how we could go ahead with us. So now let me invite the first speaker, or before I invite the speaker, let me invite the moderators for this session. Dr. Marcelo Grunberg. Good morning, Marcelo. I thought I had lost weight, but you seem to have lost double of what I have lost.
Good morning, Gautam. It's a pleasure. It's very nice to see you again, you and all our friends there in India. Really, the scientific meeting didn't start yet, but I have already learned a lot in the way you handle this, the spirit you give to everything. So I am honored, I'm proud, and I'm sure you are going to have an outstanding meeting. Thanks again for the invitation, Gautam. Thanks, Raja. Thanks, AJ.
My friend and colleague, Dr. Ajay Shetty, is unable to make it today. I will be replacing him as one of the moderators, and I don't see Dr. KV Menon come in. Can I request Dr. Srivastava to join us as a moderator for this session? And without much ado, can I request the AV team to invite Dr. Vishal Kundnani to make his presentation on pediatric transarticular C1, C2 fixation techniques, pearls, and pitfalls.
Thank you, Dr. Gautam.
Vishal Kundnani is a dynamic spine surgeon from Bombay, one of the young, upcoming, and brightest stars on our horizon. So let us hear from Vishal.
Good evening, everyone, and welcome to ASSICON 2021. Transarticular screw fixation has proven its efficacy as one of the most stable and reliable method of fixation in reducible C1, C2 dislocations. The challenge lies in the pediatric ones. That's what we are going to discuss today. C1, C2 dislocations have a varied etiology and can present in various manners. More commonly, they present either asymptomatic or with mechanical symptoms, particularly in adults, where before myelopathy sets in, the diagnosis can be made. Management of atlantoaxial dislocation is not a brainer anymore. There are various options with their own pros and cons. And transarticular screw with wiring has proven to be the one which gives immediate and absolute stability with the most strongest fixation with almost 100% fusion rates, classically described by Magral et al. However, because of being technically demanding, it has not been used more provenly, and the reproducibility has been very low among inter-observers. The problems and complications may range from 15 to 23%, right from misplacement of screw to vertebral artery injury to graft site morbidity, and this has reduced its popularity in patients with C1, C2 dislocation. We in 2012 came up with the concept of minimal invasive transarticular screw fixation with a standalone fixation without use of wires, using small incisions, giving the idea of retrograde trajectory, which is far more precise than the conventional Magral's technique, and the results have been promising. We have always used allograft and has been published in peer-reviewed journals earlier. Some of the case scenarios proving the reliability of transarticular screw in polytrauma patients with odontoid screws, in patients with fracture lateral mass where C1, C2 fixation segmentals cannot be done, and in patients with tuberculosis where regional osteoporosis and destruction of lateral mass may preclude the fixation in these scenarios. Advantages of minimal invasive transarticular screw fixation are pretty obvious and akin to minimal invasive benefits in lumbar spine surgery. It gives immediate absolute stability with absolutely low morbidity, and that has been proven wide and spread now. The question is, can it take the pediatric challenge? Is transarticular screw as efficacious in pediatric population also or not? The challenges in pediatric population are completely different because the presentation is delayed. Often these children present with myelopathy, and that's why wiring as a implant choice is not the primary choice. You may want to avoid anything intracanal. The etiology is different. More often than not, these kids have a syndromic etiology resulting into bony anomalies, making the bony stock to be improper for any kind of implant which can hold in the form of screws. And infections and inflammatory arthritis also can lead to erosions of the bone, further complicating the matter of implant choice available in hand. The biomechanics of implants available is limited. The options of implant available is limited. And the problem is once implant fails, the salvage modalities are not defined at all. The problem gets further compounded because wires in terms of are not to be used in myelopathy patients. They can also get loosened over a period of time. Use of graft has always led to problems. And unplanned OC1 fusions, because it requires exposure of occipital upper arch of C1, can result into unplanned OC1 and C2, C3 fusions in kids in particular, is a known problem in almost 25% of patients. This is one case example which highlights everything that we just discussed, that a poor bone stock in a patient with hypoplastic C1 with absent arch where wiring cannot be done, C1, C2 screws cannot be done, and OC fusion is too morbid. And then this is one case scenario where it highlights how challenging it is to manage these patients with pediatric C1, C2 dislocations. So the question is, on one hand, wiring is not possible. On the other hand, OC fusion is something that is not possible. C1, C2 fixations have a poor purchase. Implant choice is limited. Can transarticular screw be really relied upon? Is it dependable? And if yes, is it feasible to do it in pediatric population with a poor bone mass, narrow pars, vertebral arteries are so thick out there? So is it possible and feasible? The answer to this came from the first study in 2012 by Douglas L., where he said that 91% of pediatric patients are suitable to have a C1, C2 transarticular screw. And this was the first time a landmark study that came from Douglas et al. We in our study studied anthropometrically that 91% of kids would be able to achieve the minimum pars diameter of the adult size by the time they are 8 years of age. And this was highlighted in our paper published in European Spine Journal. So now it is well established that transarticular screw is not only a gap filler, but also the gold standard in pediatric C1, C2 reducible dislocations. The only thing you have to now pay attention upon is pre-operative planning and the meticulous surgical technique, which any which ways you have to pay upon, because the margin of error is very narrow. Pre-operative planning cannot be really overemphasized, but in these cases where all these 6 principles of planning have to be kept in mind while you're planning a pediatric transarticular screw. We'll go through them one by one, where indication, reducibility, feasibility, inventory, the implant choice, and of course the trajectory has to be planned before you really plan in surgery in these patients. And this is something that everybody must pay true attention to. So let's see them one by one. The indications do not change, and so are the contraindications. The only indication of a transarticular screw is a reducible AAD in a patient with suitable bony anatomy, and this is something that has to be ensured before surgery. Irreducible AADs, which are truly irreducible, and when I say truly irreducible, only the ones which have a bony block or a malunion happening at the orientoid side are the ones which are not amenable to transarticular screw. We consider that every AAD is reducible, particularly in kids population. When I say that all the AADs in kids are reducible, what I mean to say is that something that may seem to be irreducible one on a flexion extension X-ray may not be a genuine irreducible one, because most of these will reduce the moment you give them general anesthesia and they go under are relaxed enough. Sometimes you may want to use maneuvers like pushing the C2 with a transoral technique, or you want to push the C2 from behind on the prone position, rarely requiring the maneuvers like C1 wire to pull the C1 back or joint distraction. Some case examples to show you, like in a patient with torticollis which seemed to be reducible, was reduced by pre-operative Gardner traction in these kids. Reduction by transoral thumb method should always be tried in all irreducible ones by transoral technique, and most of them will reduce. We have not faced any single case where it is irreducible unless there is a bony block present there. Another case scenario where intraoperative distraction use of PUCAs can help you reduce even the most toughest and the most irreducible seemingly ones, and they get completely reduced by use of all these maneuvers. So all of them are reducible unless there is a bony block present, which can again be caught upon pre-operatively on your CT scans and MRIs. Now, once you have seen a reducible C1 dislocation, you have to ensure that the pars diameter is minimum 3 millimeters to hold upon the implant. Why 3 millimeters? Because the current implants available are in the range of 3 to 3.5 millimeters or 4.1 millimeters. And that's why to hold the currently available implants, maybe in future if we develop more implants, but currently I would say transarticular screw is feasible with the implants available only when the minimum pars diameter is more than 3 millimeters. And this has been highlighted in both our studies of anthropometric evaluation and surgical feasibility that has been published earlier in peer-reviewed journals. It also says that 91% of kids will have more than 3 millimeters by the time they are 8 years of age, and that is why you should not be worried whether they'll be holding implant or not, and it is very well proven now. There are a wide variety of implants available. We have got our implant design where a fully cannulated Herbert screw kind of situation with a varying thread and varying pitch is available in market now. It is with various companies available, and this is something that is available and should be kept handy while planning these surgeries. A conventional Herbert screw also comes very handy, as has been a choice in some of our cases. Some case examples where a pars of 3 millimeter in a rotatory subluxation where we did a Herbert screw of 2.7 millimeters. And then this is something that we may pay attention to. Keep implants ready before you wash in for surgery. Now, this is one step that you all may want to plan pre-operatively. Like conventional Magra's technique mentions that there is a fixed entry point which is 2 millimeters above the joint line and medial to the joint line. However, in our case, we keep that entry point is tailor-made, and the only thing that is fixed is exit point, where your tip of the screw has to come in either zone 1 and zone 2, making sure that you miss the vertebral artery by a broad margin. And once your exit point is fixed, you have exposed the whole of pars, seen dorsal surface of it, seen the most medial surface of it. That gives you the trajectory, and that's why with a fixed exit point, retrograde trajectory on the pars that is visible, the most dorsal and most medial surface, wherever this line joins and falls on the lamina becomes your entry point, which is never fixed. This is slightly different from the conventional Magral technique. And this is something that must be paid attention to, that the exit point is fixed, your trajectory is retrograde, and wherever it falls on lamina becomes your entry point. And that's what we have been following so far, giving us wonderful results with no misplacement. Once you have planned it, then the surgical execution is as simple as any other case scenario. Do not expose the superior arch of C1 to avoid any inadvertent OC fusion. Do not expose the lower border of C2-3 joint, and always preserve the capsule of C2-3. Try to expose the whole of pars and the isthmus, the most dorsal and the most medial surface of the pars should be visualized right in front of your eyes, because that's where your guide wire will go. And then you can plan your retrograde trajectory. This is something that you may pay attention to, that your retrograde trajectory, wherever it falls on the lamina, becomes your entry point. And then it's all about C-arm guided guide wire passing, and you can easily run through your guide wires falling in the trajectory that you have already planned. Even in the narrowest pass diameter of less than 3 millimeters, you can easily get your guide wire in, and then cannulated drill bits and cannulated screws can then pass in, and you'll be able to get your nice hold in the screws. We always use allograft that is available in bone banks with us. Our joint replacement colleagues give a good hands-on into it, and we have been really satisfied with it without the use of supplemental wiring in any of these case scenarios. And this has given us really satisfying results so far. Some case examples where JRA and rheumatoid inflammatory arthropathy is managed in pediatric population with wonderfully placed transarticular screws giving an exit point in zone 1 and zone 2. Herbert screw in even a narrow parts of 2.9 millimeters come really handy. We already have 2.7 mm Herbert screws available in the industry. Torticollis, patients presenting with torticollis due to nodentoid malunion, already established malunion, you can again with the help of thumb push technique reduce it completely, and you don't have to really do intraoperative maneuvers to reduce them. Sometimes you may need intraoperative maneuvers, like in this particular case scenario, we not only had to do a transoral push but also a push from behind prone, and it was completely reducible even in a patient where there was established malunion happening there. Rotatory subluxations, again intraoperative distraction can help you. Smaller incisions will help you get in there, and precise retrograde trajectory gives you a tailor-make entry point there. Even in syndromic patients, it is really possible to do. Tuberculosis, where one lateral mass is destroyed, you can use it. With these kind of learning experiences we have had, we have expanded our wings, and we now are able to do the same transarticular. So even in patients with dysplastic anatomy, even in patients with high riding vertebral artery, which is not the usual place where we recommend it. However, with the help of navigation, even in patients with dysplastic anatomy and high riding vertebral artery, it is surely possible. Like in this patient with os orontorium, we are able to do it, and in a patient with high riding vertebral artery, again os orontorium, we were able to get a good fixation with the help of navigation guided transarticular screw. C2 has now become more reliable. We have been using it as the lowest most anchor in even patients with basal invagination where OC fusion is done, and even in syndromic AADs with BI, this is the most reliable and absolute measure of getting stability. Results have been extremely encouraging. We have not had a single case of non-union, and bony fusion can be seen not only on X-rays but on CT scan. A thick layer of bone can be seen to be forming. Of course, transarticular screw is demanding. Vertebral artery injury in 2 of our cases have happened in out of a series of 400 cases. However, none have happened in pediatric population and none in last 250 plus cases so far. And this is purely because of the planning that we have been emphasizing more and more in these days. Yes, there are limitations which we have highlighted in our paper on learning curve of MIS C1, C2 fixation. But remember that by the time you are done your 30 cases, you are already saturated your learning, and it's very gradual after that. So this is something that you may want to practice upon in cadaveric courses, in Sorbonne workshops, and this something will come really handy. So to summarize, pediatric transarticular screw is the new gold standard, and it is surely possible and feasible, efficacious, reproducible technique provided your minimum pass diameter is more than 3 millimeters and you pay meticulous attention to preoperative planning. Thank you so much.
So that was a lovely presentation, Vishal. I open the presentation to the house. Any questions? First, I would like to ask our Argentinian colleagues to have a go if there is any question or anything that you would like to clear on this.
Yes, can I do a question?
Yes, sir, please.
Well, very interesting presentation. Thank you. I have a question about the vascular situation. I want to know do you do any vascular image usually or frequently in children to do this technique, or just we don't need it to do?
So very, very interesting question, Dr. Pablo. Thank you for bringing up this question there. So vascular CT angiograms, initially for our first 50 cases, we regularly used to do it. But now we avoid doing a regular CT angiogram to study the vascular anatomy unless and until there is a bony anomaly. There are multiple papers which suggest that the chances of having a vertebral artery which is anomalous in nature, they are usually associated with one or other kind of bony anomaly. So in kids where there is no bony anomaly, we would routinely not do a CT angiogram now. However, having said that, for all beginners, for initial first 50 cases, I would recommend that everybody should do a CT angiogram to check and find out if there is a high riding vertebral artery or an anomalous vertebral artery in the C1, C2 space where maximum dissection happens. Again, as I mentioned, the high riding vertebral artery, just to have a diagnosis of high riding vertebral artery where transarticular screw can become a challenge, you necessarily don't need a CT angiogram. You can actually study the minimum pars diameter. And if it is more than 3 millimeters, I think it is extremely safe to do, even when the diagnosis of high riding vertebral artery has been made by a radiologist.
Gautam, may I?
Yeah. Yes, please, Marcelo.
The presentation was outstanding. I mean, you went over almost every detail. There's not too much to answer because it was really to ask because it was really very clear. But my question to you is, what happens if your measurement shows you that you have less than 3 millimeters? Which is your usual option, alternative option?
Very interesting. Again, Marcelo, as if the minimum pars diameter preoperatively is less than 2.7 millimeters on both sides, then I would preclude using a transarticular and rather depend on only C1, C2 wiring. Because the moment pars diameter is less than 2.7 millimeter, there is no other implant available currently in the industry. Now, again, it brings me to an interesting part of this, that 80% plus kids more than 3 years of age have their pars diameter, which is more than 2.8 millimeters. We recently have published a study on anthropometric analysis of minimum pars diameter in kids more than 3 years of age. So every kid, I would say 80+% of kids who are 3 years and above, their pars diameter is already 3 millimeters and above. And so the chances of you getting a pars diameter less than 2.7 millimeter in a child of 3 years and elder one is less than 15%. So I would say that it's very rare to see a pars diameter of less than 2.7 millimeters unless it's a grossly syndromic craniovertebral junction, where again you would rather rely on either C1, C2 wiring if it is possible, or you would do a OC fusion. Now the other fallacy to this is the moment you see a pars diameter of less than 2.7 millimeter, where there is already a syndromic craniovertebral junction, the chances that you will have a complete C1 arch to hold on wires is also extremely rare. And that's why the only choice that will be left behind to you is OCT.
Right. Any other questions before we move on? No.
Yes.
Okay. Thank you. Yeah, Dr. Bernasconi, please go ahead.
No, it's just a question about the cannulated screws. Do you use every time a cannulated screw, Vishal?
Yes, Dr. Pablo. It's again very interesting. Unless until you pass in your guide wire, it will be extremely impossible to drill it freehand because you have no second chance to drill in there. And that is why to not use a cannulated screw becomes extremely difficult, because otherwise getting your guide wire in, and in these soft bones, if you don't run your cannulated screw on the guide wire, the chances that a solid screw may pass into a different zone completely is very high. And that's why I always use a cannulated screw which can pass on a guide wire.
Thank you very much, Vishal.
Thank you.
And that was a lovely presentation. I think fantastic, as Marcelo said. Can I request Marcelo to invite the next speaker, please?
Yes. So please, I would invite Juan Emmerich. He's a neurosurgeon from the city of La Plata. He's a very well-known here in our spine community. Juan, are you ready to join your screen with us?
Hi, hello, good morning, good afternoon, good evening. My name is Juan Emmerich. I am a neurosurgeon from Argentina. It's a huge honor for me to be here. Thank you so much to the scientific committee for this beautiful invitation. I learn a lot from the Indian surgeons every time I meet them in an international meeting. So again, this is a huge privilege to be in front of you. Thank you so much for this kind invitation. My lecture will be a surgical approach for cervical spondylotic myelopathy with kyphosis. These are my disclosure and my academic affiliations. I don't have any conflict of interest for this presentation. We have three main objectives for today's presentation that are mainly identify which are the goal when we treat this patient, describe the different scenarios in which patients with kyphosis came to our practice, and finally, which which is the best surgical approach for each case and how to perform a successful surgery. If we made a review of the actual papers, we are going to identify that there are not a clear rule of how we deal with these patients. There are authors who say that we can go for an anterior approach alone, others who say that we need to go for a posterior approach alone, and we have authors as well that say we need to go in a 360 approach with an anterior and posterior combined in the same surgery. And this is extremely important because in some way all of them are absolutely right, because we need to understand which will be the objectives of our surgery. When we treat this patient with a surgical treatment, we try to achieve the compression of the spinal cord, to have the spinal cord centered inside the spinal canal, and of course leaving a stable spine. And as already says, we can reach these objectives with different approaches. There is not only right way to achieve this. So just a few examples of patients who came to our practice, and as you can see, we treat this patient with the anterior approach alone, posterior approach alone. Just as example again, laminectomy plus fusion, laminoplasty. So there is not one rule that say all these patients, even with patients with kyphosis, need to be treated for anterior or posterior approach alone. How we can select the right surgical treatment for each patient? There are three issues that we need to keep in our mind when we decide how to treat these patients, and these are the etiology of the cervical myelopathy, the level of compressions, and the radiological alignment. This is absolutely different when we treat a kyphosis or a cervical deformity that it's from a degenerative disease, like in the cervical myelopathy usually, or we are treating a patient who came to our practice with a deformity after a tumor, a trauma, an infection, or even worse if it's after a previous surgery. And why this is so important? Because the papers who show a clear link between the outcome and the level of correction that we can achieve in the surgery when we treat these patients are mainly in patients who have a trauma, a tumor, infections, or iatrogenic deformity, not in the patients who have degenerative disease. And this makes a lot of sense because the patients who have trauma or infections used to have, let's say, a normal alignment in their spine, so they have an acute disease who change that reality. It's totally different in patients who have degenerative disease. Another important issue is to understand if we are dealing with a single level compression or a multi-level compression, and probably even more important if we have a patient with a normal canal or a narrow canal. If we are dealing with a patient with a multi-level compression and a narrow canal, probably we need to think in a more comprehensive treatment because that patient need a multi-level treatment. And it's different if we are dealing with a normal canal and a single level compression, that probably we only need to make our focus in that level and forget about the rest of the spine. When we think in the radiological alignment, at the beginning it looks very easy. We have 4 different possibilities. There are lordosis and straight spine, sigmoid spine or kyphosis. We can see a few examples. However, we are learning that the cervical alignment it's not isolated from the rest of the spine. Many papers are showing to us the importance of the T1 slope, and we know how the sagittal balance have an impact in the cervical spine. And probably more important when we talk about radiological alignment, it's to keep in mind that it's not the same, the alignment in the X-ray or the MRI. And I believe everybody agree that we need to take these measures in X-ray. However, when we decide how to treat these patients, we always look the MRI to select if we go to an anterior approach or a posterior approach. For all that reasons, we decided 25 years ago in the 1990s, change the concept of release and correction of the axis by to try to achieve that we call spinal cord alignment. With that concept in mind, we look for the spinal cord above and below the compression and identify a place where the spinal cord is centered inside the canal. Then we draw a line that joins both points, and we call that line posterior spinous line. We published this in 2006, and since then we are using to decide when we go for an anterior approach or when we go to a posterior approach. So we can have two possible scenarios. One that we call negative, it's when the spinal cord is behind that line, or positive, that it's when the spinal cord is in front of that line. And we use this concept to decide, like I told you, how we're going to treat this patient. So for us, when this line is negative and we have a multi-level or a single-level compression, will be an indication to go to an anterior approach. In these cases, we decide to perform discectomy or corporectomy of one or more levels. Let me show you a couple of examples. This patient with a single level compression in a normal canal, we decide to perform a corporectomy and fusion with a very good outcome with a follow-up of 5 years. Especially in the single level compression, there is not only one solution. You can choose from the different techniques, and mostly of them have a wonderful outcome. Here different techniques, very old patients, treating some of them 20 years ago with a really good follow-up and an excellent outcome. And when we go with the posterior approach, when this line is positive, and especially when we have multi-level compressions. In that cases, we have the possibility to choose a laminectomy or laminoplasty. Both of them could include some kind of fusion. And let me show you a couple of examples of patients who have strides or with a small kyphosis spine to show you how we can use the posterior approach to treat these patients. This patient, 75 years old, again we mark this line, and in our concept allowed to go by the posterior approach. Of course, he have a fixed spine, so we decide to perform a laminectomy without fusion. Here the pre and post with a good outcome and 6 years follow-up. Another case, this patient could be treated by an anterior approach with any doubt, but we decide to go by a posterior approach because he have a multi-level compression. In this case, we chose a laminectomy plus a fusion with a pre and post with a 7 years follow-up, again with a really good outcome. And finally, a very tricky case, a male, 72 years old, with instability for walking, with rapid progression that was really worsening in the last 7 days, difficulty for fine movements in both hands, and loss of strength in 4 limbs. You can see here the sagittal and axial MRI. This patient could be treated with any doubt by an anterior approach, but we decide that we can fix this pathology with a posterior approach, preserving some mobility that the patient have at that time, and especially to treat the levels before and below the most worst part of the compression. So we decide to treat by a laminoplasty. So we perform in this patient an extend laminoplasty from C2 to T2. Of course, this is not the usual laminoplasty. And as you can see in this 1 year follow-up MRI, we achieve a very good decompression of all the levels. Here you have a pre and post with 1 year follow-up. These X-ray are 2 years after the surgery, and you can see that the patient keeps some mobility of the spine. Here are the pre and post, and again, with any doubt, most of you could treat this patient with the anterior approach and with a very good outcome, but we believe that there is place for the posterior approach in the cervical myelopathy with kyphosis if we select the right patients and we use the right treatment. As conclusion, we can say that to select the approach and the correct techniques, we need to keep in our mind the stability, if it affects one or several levels, and especially, at least in our concept, is the position of the spinal cord inside the canal. There will be patients in whom the indication of anterior or posterior approach seems very clear, and I believe mostly of the surgeons don't have any doubt, but will be many cases, it will depend on the preference and experience of the surgical team.
Thank you very much, Dr. Emmerich. That was a wonderful presentation. I think a very novel and a new concept. Have you published this at all?
Yes, thank you. We published in 2006. My boss and my professor is Nestor Fiore, a really well-known surgeon here. And we spread probably this knowledge in Latin America, but we are a little bit lazy, and perhaps we don't spread too much outside Latin America.
Whilst the others warm up to ask you questions, let me put you the first question to you. Does the line only dictate whether to go anterior or posterior, or does it dictate the length of your decompression also?
Yes, amazing. Thank you for that. The good idea behind this concept is that not only select the approach, but give you, as you well says, the level of the compression we are going to search. Some of the critics could say that we are moving this line one level below or one level after that, but the idea is that we can project, and we have more than 300 patients following this rule, and we can project in a very good way the final result, the outcome. So it's not only compared with the key line that is a similar concept. It's not only compared when we go to an anterior or posterior, but as well we can decide the level of the decompression with a good, follow-up.
Before I ask Dr. Srivastava to ask a question, there is a question from the audience, and that is, can you please repeat the marking points for the line?
Yes. So we identify the level of compressions, and we look for one place when the spinal cord is in the ideal position. That means center in the canal and with CSF in front and behind. So that will be at least our ideal points, one in upper and one below the level of compression. And then we draw a line that go in the union of the lamina and the spinal process, and we can identify from that level if our decompression, because that is the idea behind the concept, will be enough to leave the spinal cord center in the canal and with a good evolution.
Right. Dr. Srivastav?
Yeah. So very good paper and paper you read just now, Mr. Juan. I have two questions simultaneously. One is that if you have a dynamic instability where you feel that this laminoplasty is not going to help, do you change the plan? That is one. And second, do you have increased incidence of C5C with such a long laminectomy?
Yes, thank you. Both are really nice questions. The first idea is, of course, very clear. We use laminoplasty only when we don't have instabilities. If we have instability, we perform laminectomy plus fusion, or even in some cases, we perform a huge laminoplasty, not huge, I mean from C3 to C7, and perhaps if there is a very focused instability, we only fix that level. Could see, you know, C6, C7 sometimes, but depends patient by patient. And the second question was about C5 falsi. You know, I see plenty of papers who show this C5 falsi. However, we have plenty of complications. We are very far to be perfect, but we don't have too much C5 falsis. And I believe that is something related with the technique. We try to be, you know, very, very clear that the compression is good. We sometimes add a foraminotomy, but again, this don't mean that we don't have complications. We have plenty of complications, but at least in our series, to be honest, we have only one patient in more than 300 patients with a C5 that was only 2 weeks, and then he have a full recovery.
Questions from Dr. Pablo? Dr. Bernasconi?
Yes, hello. Hello, Juan, a pleasure. I have a question about, it's a technical question about the C3, because I saw especially in the last patient that you showed, that you are doing a laminoplasty at C2 also and C3 level. There is like a new concept that doesn't work. What is your opinion?
Yeah, you know, usually the traditional laminoplasty we perform, it's from C3 to C6. That is the usual laminoplasty, because as I understand your idea, when we perform a laminoplasty in C7 or in C2, it's always that huge doubt about the muscles and how it's gonna go this patient to a kyphosis later. And I bring these cases, I know Marcelo Gruenberg knows this case very well, because always it's extremely controversial. You know, you say, when I don't see too much cases that we go to laminoplasty to T2. We include C2, not so many times, but we do plenty in C2, 20, 25 cases, but not too low than T2. But again, the concept is that we can use in very select patients, we can include C2 and C7, because if we have in our mind that we can include C2, we saw plenty of patients that have a good laminectomy from C3 to C6 to C7, but remain with a compression in C2, and that is really, really bad. If you're not so happy to perform a laminoplasty in C2, you can perform a laminotomy in C2, a partial laminotomy, trying to protect the muscles and just perform in the, you know, in the half below the level of the muscles, and could be effective. But I understand that this is a very controversial case, and that is the idea what I bring here.
Last question from Dr. Marcelo before we actually move on to the next talk.
Thanks, Gautam. I'm aware of the work that Juan and his colleagues from La Plata are doing. I mean, the work is outstanding. They are so expertise in this that they move the indication to almost everybody. And if I have to have a laminoplasty for myself, I will travel to La Plata, not with Juan because I cannot afford his fee, but to one of his colleagues. My question will be, with this disclosure, my question will be, when you draw the line that we draw it and we learn it from them, we are aware that we do that with the MRI, but then the patient have another posture that is more related to the standing or sitting X-ray. And the MRI reflects the position in which the technician put the patient for doing the procedure. So I wonder if they have any special measure to know that the MRI reflect what then is going to happen when the patient is sitting or standing.
Yes, that is an excellent question, Marcelo, as usual. And you can came to the Plata, I go to do a special discount for you. Don't worry about my fees. Take it easy. So yes, especially we perform all our MRIs when we have a laminoplasty with a particular doctor who he pay extra attention how he position that patients. It's not easy because this is not 100% of the cases. But again, I believe the important, it's if we say that the patient is in kyphosis or in lordosis, we learn from the beginning that we need to follow the X-ray. So here in the MRI, more that if we are looking that the patient is in kyphosis or lordosis, we are looking the alignment of the spinal cord inside the spinal canal. And at least in our concept, this is not so affected for the position of the patients, because again, theoretically, when we open that spinous process, we're going to have enough space to the spinal cord could be, free inside the spinal canal. But I fully agree with you. The MRI depends a lot of the position of the patient inside the equipment. That is absolutely true.
Thank you very much.
You're welcome. You are on mute, Gautam. We can see you, you're moving your lips, but we can listen to you. You are still mute.
Hello.
Yes, we got it. We got it.
So, yes, Marcelo, we are running about 7 to 8 minutes behind time and we need to buck up. I'm going to invite one of the dynamic spine surgeons from a city in Western India called Ahmedabad. And he is one of the pioneers of minimally invasive spine surgery.
Dr. Amit Jhala's presentation, please.
First of all, I would like to thank Association of Spine Surgeons of India for giving me this opportunity to present. And we all know that direct decompression is the traditional conventional procedure with a transforaminal lumbar interbody fusion for degenerative spondylolisthesis. And you can get a very good result clinically, as well as around 95% of fusion rate in this TLIF procedure. What I'm going to present is what is the role of indirect decompression in degenerative spondylolisthesis. Now, this is a patient of degenerative spondylolisthesis with an actual MRI showing moderate grade of lumbar canal stenosis. And the question is, does this patient require a direct decompression? What we did was an indirect decompression, and what we could achieve by just putting the cage anteriorly is reversal of the disc bulge, stretching of the ligamentum flavum, distraction of the facet joint, and you can see there is a whole lamina which is intact, and reconstruction of the whole spinal canal with a good increase in the cross-sectional area. And in sagittal image, you can get a good disc height, you can get a good reduction and a good lordosis with opening up of the spinal canal. So if you see, this is a more of a physiological approach. And if you see the pathogenesis of degenerative spondylolisthesis, there is a loss of disc height which gives rise to ligamentum flavum buckling. There is ligamentum flavum hypertrophy because of the hypermobility. And because of the degeneration of the facet joints, what you can get is a static compression because of the loss of spinal alignment. And all these things can be reversed by just inserting a large spacer which goes from anteriorly, which goes from one end plate to the other end plate. And what you can get is stabilization of the spine, jacking up of the disc space, reversal of the buckling of the ligament and PLL by ligamentotaxis with alignment of the spine and a good indirect decompression. Over and above this, there is a large area of the fusion which you can get because you are going anteriorly, and good amount of disc space clearance that you can do. And everything can be achieved either by OLIF or XLIF, but my personal choice is an OLIF procedure. And you can see in this case that there is a loss of disc height, but you can see how much amount of distraction that you can get, and that's the power of jacking of the disc space. You can get a good realignment of the spine by inserting this large size cage. So there is a big principal change which has occurred from PLIF, which did a laminectomy and bilateral grafting, which had increased neural retraction and increased chance of deficit, to a TLIF procedure, which is a gold standard as on today, where it's a more destructive approach, according to me, where you do a lot of facetectomy, you enter the spinal canal with all the problems of neural retraction, neural injuries, and chances of neural injuries. Compared to that, OLIF, there is no morbidity of the posterior approach because you are not going through the paraspinal muscles, so you are not entering the spinal canal, and all its eventualities of neural retraction and epidural bleeding that can be avoided. There is no parietal fibrosis, and because you are going more anteriorly, you have a better disc clearance, you have a better biomechanical position for the cage, and you get a good lordosis. So there is a principal change from TLIF to OLIF, and the main important part is In degenerative listhesis, these are the different actual images of the patients having degenerative spondylolisthesis. And the question is, how much is the indirect decompression? What is the limit of the indirect decompression? Whether it is limited to only instability and foraminal stenosis, or you can stop at a moderate canal stenosis level, or even you can go up to the severe canal stenosis as is shown here. So this is the case of Shizas grade 1, a fairly simple case where there is just a foraminal stenosis, and by putting and jacking up the disc space, you can increase the foraminal diameter and stabilize the spine, and you can get a good result. But this case, there is not only a foraminal stenosis, but there is a ligamentum flavum hypertrophy and a central canal stenosis also. And by indirect decompression, you can just achieve a good canal clearance even in Shizas grade 2 with a moderate type of stenosis as is shown in this case also. So the question is, how much indirect decompression? And so what we have done is we have selected few articles and tried to find out what is the increase in the spinal canal area. And if you see that the first publication was from Oliveira in 2010, and there are so many articles in 2020, but these are the select few. And what I've done is try to find out what is the difference between the initial learning phase of indirect decompression and what is going on as on today. And you can see that initial case in initial series, what the spinal canal area that you could achieve was around 30 to 33%. But in recent articles, you can increase the spinal canal area by 140 to 172%. And no patients, fortunately, right from the first article, except the 2 patients in Oliveira, which was a standalone case, cages, none of them required a direct decompression, and all of these patients clinically improved. So in 2017, Roger Hartle group, they published this potential and limitations of indirect decompression. What they concluded that this is a very good technique for decompression of the foraminal stenosis, but the evidence on decompression of the central canal was lacking according to them in 2017. But there are so many articles which have come after this article. And this is one of our publications, and this is what we are following right from 2016. And this was a publication of 60 segments. We could get around spinal canal area improvement in 42.7% and a good clinical result in 97% with no patient requiring a direct canal stenosis, direct decompression. But what we did was a subgroup analysis in the same series, and we could find that the spinal canal improvement was much more in severe stenosis. And so we decided and looked back to our cases with more of Shizas grade 3 and 4. So this is one of the case with Shizas grade 3. And you can see the amount of decompression that you can get, or spinal canal area improvement you can get, is much more in Shizas grade 3 and Shizas grade 4. This is another patient, Shizas grade 4 or a D. And you can see how much amount of decompression or spinal canal area improvement you can get. You can get a good canal reconstruction in sagittal images also. Another patient, a severe degree of or grade D type of Shizas, and you can see how much amount of decompression that you can get or improvement in the spinal canal area you can get post-operatively. It's a quite huge amount of improvement that you can have. Another patient with similar kind of a result, you can get a good amount of spinal canal area improvement in Shizas grade D type of cases. And this is what we presented in ASSICON 2020 with 105 segments which were evaluated between 2016 and 2020. And we did a subgroup analysis of 44 segments which belong to Shizas grade C and D. And we could get indirect decompression which was effective in these cases also, with a good fusion rate of around 93%, and no patient required a direct decompression. And we evaluated the foraminal height, disc height, but the most important is the improvement in the spinal canal area, which was much more, which was 42% in our initial series to 75% in these cases. That means you can get a good amount of canal clearance in higher grades of Shizas lumbar canal stenosis. The similar results are produced in other the studies also. This is a very good study They studied just scissors grade C and D with 1 year follow-up study, immediate MRI and 1 year follow-up study MRI. And no patient required a revision surgery in that study. And you can see the overall expansion was around 274% with 88% fusion rate. And you can see that in this, one of the examples that they have published, you can get around 580% of the expansion. So it is effective option even in severe lumbar canal stenosis. That was their conclusion. In one more study, which they have followed up for about 2 years, and they have said that you can get a progressive increase in decompression because there is remodeling of the spinal canal. There's thinning of the ligamentum flavum as your follow-up increases. And you can see that this patient, which was scissors grade C, which improved to actually scissors grade A in 2 years follow-up. And there's a progressive increase in spinal canal area, which increases in their series from 140% initially to 189% at 2 years follow-up. And therefore, the indirect decompression produces immediate positive results, but that continue to improve over the time. And the cross-sectional area of the thecal sac actually doubled after 2 years. And the similar result in the long term has been already published. And this is a 10-year MRI study of an OLIF with indirect decompression. And this is their case that they showed that in 10 years, there is actually hypertrophy of the ligamentum flavum because of the fusion. And their conclusion was that stability of the spine may have induced the change of lumbar ligamentum flavum, and there is remodeling of the spinal canal. So definitely, as you follow up more and more, there is remodeling of the canal, and you can get a better and better decompression. Now, there are certain factors which are very important for successful indirect decompression. And you know that the indirect decompression basically depends on the jacking up of the disc space. And for jacking up of the disc space, you require a good bone quality. So if you don't have a good bone quality, or you have an osteoporosis, this jacking up may not occur, and you may have actually a damage to the end plates while jacking up. So it's not a good candidate. Osteoporosis are not a good candidate for this type of decompression. We all know that we have a good data for moderate central canal stenosis also. But in severe, that means scissors grade D, the data is still lacking. And it's very important that you have a very good footprint of the cage, which goes from end to end. If it does not go from end to end, again, you cannot jack up, and you may actually, there is a cage subsidence, and you can get a recurrence of the symptoms. So these are very important factors to consider if you want to go for an indirect decompression. So overall, the indirect decompression significantly increases the overall spinal canal area by stretching the ligamentum flavum. Though some amount of compression is visible in post-op MRI, gradually there is remodeling of the canal by hypertrophy of the ligamentum flavum in long term, maintaining the decompression effect or increasing the decompression effect. And direct decompression is not the only pathology in unstable lumbar spine. Actually, it is dynamism which plays much more important, and stabilization itself gives a clinical result initially. And objectivity actually needs to be assessed regarding the role of indirect decompression and the amount of compression. Thank you very much.
Thank you, Amit. That was a lovely presentation. I will invite 2 questions from my Argentinian colleagues today. Dr. Bernasconi, you have a question for Dr. Jhala?
Yes. Just, I have a question, of course, about the indirect decompression, and also to decide which is the best method to do. And some authors, they mention a lot the ligament buckling to decide which kind of method can I use. For example, an X-leaf or an OLIF. I want to know his recommendation, please.
Basically, thank you for the question. My main personal choice is to do an OLIF because of multiple reasons. One is that it is much more safer compared to the X-leaf, because you are going anterior to the psoas, and the chances of getting the thigh pain and the lumbar plexus injury is much, much less. The second is that your limitation of X-leaf at L4-5 is much more because of the prevention of the high iliac crest, and that may not allow you to go for X-leaf procedure. But as far as the decompression is concerned, I don't think there is any difference between the X-leaf or an OLIF procedure. So, but that's a personal choice. Plus, there is no need for a neuro monitoring if you do an OLIF procedure. So these are the advantages why my personal choice is an OLIF rather than an XLIF procedure.
Yes, any more questions? If not, then I would like to ask Dr. Marcelo to invite the next speaker, please. Thank you, Amit.
Thank you.
Thanks, Gautam. Thanks again. Well, the next speaker is our Spine Society president. He still have 2 more months as the president. Juan Pablo Bernasconi is going to talk us about a subject, a topic in which he has a good experience, multiple rod instrumentation for spinal deformity. Please, Juan Pablo.
Thank you very much to invite me to this fantastic meeting. It's a really great pleasure for me and also for the Argentinian Spinal Society. So thank you very much. So I'm going to talk about the multiple rods constructions, instrumentation in adult spinal deformity. The adult spinal deformity, everybody knows, is a very controversial topic, chapter, with a very important complication rate, especially the late post-op complication rates, that they are very high, relate to the implants. The most common cases are hardware breakage or implant breakage, implant loosening, loose of the correction, non-union, and several causes around 30 or 40%, especially at the lumbosacral junction transition, at the osteotomy place, at the vertebrectomy place. So it's a very complicated pathology to approach with a very important rates of complications. One thing is a fact today that we are operating older people than years ago. That's first because the life expectancy is very high today in most of the countries around the world. And if you see here the sentence in red, this is the number of patients operated between the period 2004 and 2015. It's around a double. It's a progressive growing of the patient, or the older patient that we are operating. And this is a very interesting new concept. This is a concept that the scientific called super aging society, means that 20% of the population in one country have people with more than 65 years old. The point is that today there are 5 countries in this condition, this situation. In Europe, at the head are Italy and Spain, but in 2030 will be 34 countries. So the number of patients, the older patients become larger than years ago. This is, for me, a very interesting graphic to understand what happens when we operate on the spine and we do a correction, an osteotomy, and vertebrectomy, etc., etc. Usually at the beginning of the surgery, we are leaving the hardware in the very stiffness situation to provide a very good stability, and at the same time, we are leaving the graft ready to grow. So at the end of the healing process, we can say healing process, that takes around 24 months, we will have a very good bone fusion and we don't need more the hardware. This is the classic spine crossroad that usually we can observe this in healthy people. But in the adult people, and especially in adult spine deformity, the situation is pretty different. Because you can see here in the list in the left side, first is the patient older. Second is a patient with very poor bone quality. That's very important. Then the cigarettes plays a very interesting role in the complications. Sometimes with the diabetes, obesity, and became very more frequently the extrapyramidalism syndromes that are very common in this kind of pathology in old people. The other point is that, in my opinion, we are finding more complex deformities. And these complex deformities, not in all the cases, they are primary. In most of the cases, they are secondary to the multiple surgery, so became more complicated treated. In the second list, over this situation, usually we are doing a very aggressive technique, surgical technique in the adult spinal deformity, with a very, sometimes the degree, the rate, the correction rate is very high. The bone resection became very large in some cases, with pedicular osteotomy to 1 level, 2 levels, vertebrectomy, and in most of the cases we go to the fusion to the pelvic. So the scenario in this particular chapter, adult spinal deformity, is not very nice. It's a very risky scenario. So to obtain the crossroad spine variables necessarily can be pretty difficult. Why we use the multiple rod contraction? We try to use multiple rod contraction just like a mechanical way to try to improve the stiffness and the stability at the beginning of the surgery and during more time, with the main target to improve the fusion, to keep the correction, to avoid the complications that we can have, especially the late complications. The multiple rods contraction, you can use it, I use alone sometimes, and I use combined with any anterior supports, I mean OLIF, exit, etc., etc. 2 articles that for me, they are very, very interesting is this article about Manish Gupta presented at the SRS in Montreal a couple of years ago, when he classified the different constructions with main roads, accessory road, and satellite roads. Very interesting. Here's a result. We can see here in the left side the difference result, the different consolidation rates using the different constructions. Another article that is very interesting is the article by Pedro Bercano and Claudio Lamartina that they did an finite element model using one construction that they call delta cross road. Very interesting to reduce the stress and very interesting to reduce the torsional loads. The torsional loads are the principal factor that can produce implant loosening in the interface between the bone and the screw. So this is a very, very interesting paper, both of them to read it. Let me to show you a couple of examples about the surgery that we are trying to do with multiple rod contraction. This is the patient young, 48 years old, operate 4 times. She began with a decompression alone, then decompression plus fusion, then infection, implant removal. So she developed this iatrogenic deformity. So we treat with the multiple rod contraction in terms to improve the fusion and the stability at the beginning of the surgery and during a period of time more than 1 year to maintain the correction and to improve the fusion. This is another patient. This is the female with the Parkinson disease. Operated 2 times, decompression alone and then decompression plus fusion. This is has a situation with a rigid deformity in the sagittal plane, also with a fracture on the top of the instrumentation. So this is the procedure that we did associated with multiple Smith-Peterson osteotomies at the kyphosis level. And then you can see the classic construction that we are doing since 5 years, 6 years, using the main road, 2 main roads, you can see here the graphic, attach the main rods attached to the pedicle screw, and then 2 accessory rods attached to the main rod with a couple of dominoes. Usually we attach directly the accessory rod to the iliac screw with a very good result. It's a very easy construction to do. This is another patient. This is a male 5 times operator. He started with decompression, the simple decompression, and then with the arthrodesis, then a PGK, then infection, then implant removal. And he developed this pathology as another kyphosis, pretty flexible in the sagittal plane. So we did the same, multiple Smith-Peterson osteotomies, and then the instrumentation using the same concepts, main rod, an accessory rod attached, in this case, particular case, with 2 dominoes and attached directly to the pelvis. This is another classical rod breakage of the lumbosacral junction. Very common, the cell arthrosis and the non-union rate and the lumbosacral transition is, everybody knows, around 30% is very big. There's a classic with a coronal imbalance. So here we prefer to combine a method. We did first an OLIF, like an anterior approach, and then we did the posterior approach, making this classic construction with a good result in the sagittal and in the coronal plane. Here, another example, this is the female with a classic PGK developed, like you see here, 6 months after surgery. The patient presents with pain, of course, and neurologic compromise. So I did this second surgery using the just a simple contraction attached by dominoes. It was a mistake. So you can see here, after 1 year, rod breakage at the transition area first. And if you see more specific this part, the anterior aspect of the spine, I think everybody think here that needs a pretty support. So we did the first procedure, and I hope that will be the last, using the combination of method, the lateral approach to put 2 cage, 2 X-sleeves at this level, and then the classical contraction with multiple rods. So very interesting. Our experience with multiple rods in this kind of pathology, especially in revision surgery in older patients, are very, very good. This is another contraction that I show you the article by Pedro Berjano and Claudia Lamartina. This is the patient operated 2 times. And also she has a bariatric surgery for obesity. Led me to remember that the bariatric surgery and the spine surgery, for me, are enemies. It's a very dangerous situation, operate a patient after a bariatric surgery. She developed an additional syndromes that we treat using a combination, a couple of X-sleeve, and then the classic cross, the delta rod technique of contraction. Very interesting in the delta contraction, the delta rod contraction in patients with osteopenia, because she has a very good impact in the torsional loads. And everybody knows here that the torsional loads are a very important factor to reduce the implant loosen. So it's an attractive option in patients with osteopenia, and in cases that we don't need to go to the sacrum or to the pelvic. So the summary, I think that the most important situation that, or the most important scenario that to try to obtain with the spine surgery is this, the crossroads spine, because we are compulsory to do these crossroads variables between the hardware and the graft. This is very difficult. There's a pretty difference in healthy people than in adult spinal deformity. So the multiple rod contraction alone or combined with any anterior supports is a really very good mechanical option to try to improve our results in this complex pathology. So, thank you very much for the invitation again. It was really a pleasure. And I hope that one day I will see you in my country, Argentina. So you are welcome. Thank you very much.
Dr. Bernasconi, we look forward. We've heard so much about Buenos Aires and how lively a city it is, and we would love to be there at some point in time. The fantastic talk. I think this introduction to a multi-rod concept is very different for us because we have used them for crossing a pedicle subtraction osteotomy, but I saw that you use it for a lot of other cases too. Any questions from our panelists over here on the platform for Dr. Bernasconi? Yes, Dr. Srivastav?
Yeah, so very good concept. I just wanted to know, with the supplementary rod which you go to pelvis, do you make any effort to correct the pelvic tilt, or it is just a supplementary rod?
No. Can I use? Can I do the both techniques? Can I try to correct the pelvis retroversion and to try to maintain, and then to put the supplemental rod? It's the same. The use of the supplemental rod at the lumbosacral junction is because the cellular arthrosis rate is very important. So it's a good option.
Dr. Bernasconi, there's a question that when you put in 4 rods, your muscle closure over that is a little difficult. You're creating greater dead space. How do you circumvent that?
No, I haven't. The muscle cover, you tell?
No, how do you, when you put in 4 rods, it creates a lot of dead space. So how do you tackle the dead space which is there? Is there a problem?
No, I don't understand, sorry. Dark space? I don't understand.
Dead space. Dead space means a lot of leftover space because tissue does not close properly over it.
No, but I haven't any problem.
You haven't had any problem. That's great. Thank you very much, sir. Any other questions before we move on to the next presentation? Sushil, can you play my presentation? I am the next speaker.
Yes, sir.
Do you want me to present you, Gautam?
A 47-year-old lady presented to us with back pain for 6 months, increasing pain since the last 2 weeks, and a progressive paraparesis so that she was unable to walk since the last 3 days. Examination revealed a spastic paraparesis with power being grade 3/5 in both the lower limbs. X-rays showed a D4 pathological fracture, and the MRI confirmed the presence of a D4 fracture with retropulsion of bone and extension of soft tissue into the epidural space, resulting in spinal cord compression. The axial cut showed that there was bipedicular involvement with extension into the epidural and paraspinal space. A CT-guided biopsy was done elsewhere, which revealed a vertebral hemangioma. Hence, a diagnosis of aggressive vertebral hemangiomas was made, and the question then arose, how should we proceed? There are a number of options available, which include transarterial embolization, ethanol injections, vertebroplasty, radiation, and a number of combination of these along with surgery. This talk aims to describe the current management of aggressive vertebral hemangiomas. Aggressive hemangiomas form 0.03% of the ubiquitous and commonly benign vertebral hemangioma. 2 to 30% of them are multiple, especially if they are thoracic hemangiomas. These aggressive hemangiomas are far more common in women between the age of 40 and 60. They usually start in the vertebral body and then go on to involve one or both pedicles and then spread into the epidural space and paravertebral tissue after causing cortical destruction. Histopathologically, a regular hemangioma is a slowly growing hematoma. It has dilated, thin-walled vascular channels which are set up in a stroma of fat, and these are interspersed among thickened bony trabeculae. Aggressive hemangiomas, on the other hand, have a lesser fat content and more of vascular channels. They result in a vertebral expansion and can cause spinal cord compression secondary to the expansion. They can also cause a spinal cord compression because of epidural spread of the tumor. The first investigation, of course, is an X-ray, which shows you coarse vertical striations. The sagittal CT scan mimics the X-ray picture. The axial CT scan shows a polka dot appearance because of the thickening of the vertebral trabeculae. The T1 and T2 weighted MRI scan shows a signal hyperintensity because of the hemangioma. The T1 hyperintensity reflects the fat content of the tumor, whereas the T2 hyperintensity reflects that the tumor is full of fluid. Aggressive hemangioma is differentiated from a benign hemangioma based on the level at which it occurs. Aggressive hemangiomas occur between T3 to T10, involve the entire vertebral body with cortical expansion. There is often cortical erosion and extension into the epidural space, paraspinal space, or into the posterior arch. The MRI in an aggressive hemangioma shows a hypointense signal on T1 weighted image because of the high content of vascular channels. And there is an intense enhancement after contrast. A CT-guided biopsy is unnecessary on most occasions if the classic findings of vertebral hemangioma are observed. But sometimes there may be a doubt in diagnosis, and the differentials include metastasis, solitary plasmacytoma, and lymphoma, among others. The problem with CT-guided biopsy is because there is such a large amount of vascular channels, little soft tissue is obtained for the study. Often one seems to extract only blood. Hemangiomas, based on their activity and their aggressiveness, are classified into 4 types. They can be latent with mild bony destruction and no symptoms. They can be active with bone destruction and some pain because of pathological fractures. Or they can be aggressive with epidural or paraspinal spread and neurologic deficit. The treatment options are varied and many. Direct ethanol injection into the tumor, transarterial embolization, and vertebroplasty or kyphoplasty have all been shown to work in terms of destroying the tumor, but they are meant only for tumors which are well contained within the vertebral body. Radiotherapy, on the other hand, is known to cause vascular fibrosis and impairment of the circulation of the tumor. Haid reported a complete resolution in 79% of aggressive hemangiomas after a high-dose radiotherapy regimen consisting of a total of 3,400 rats. The problem with this radiotherapy in patients with a progressive neurology is that their symptom relief often takes a fairly long time. And therefore, currently, radiotherapy is primarily indicated in the post-surgical setting to prevent a local collapse. It is contraindicated for large tumors and tumors invading the spinal canal that result in a significant neurologic deficit. Radiotherapy may lead to radionecrosis, myelitis, secondary sarcomas, and even vertebral collapse when there are extensive lesions. The surgical options for aggressive vertebral hemangiomas traditionally have been a simple decompression or a decompression with stabilization or excision of the tumor, either piecemeal or en bloc, and a reconstruction. However, majority of the surgeries today are performed by a combination of surgery with embolization and vertebroplasty to limit the surgical morbidity. Between 2002 and 2018, we have treated 15 patients with aggressive vertebral hemangiomas. Majority of them were in the thoracic spine and half of them were associated with a pathological fracture. 13 of the 15 patients had mild to moderate back pain which had worsened because of a pathological fracture in recent times. All patients had a neurologic deficit at presentation. In all our patients, we perform embolization 1 day prior to the surgery. We perform gross total resection in 9 patients, and this was followed by anterior reconstruction and posterior stabilization. Radiation was given if there was a paraspinal spread of the tumor. No recurrences were encountered at a minimum 2-year follow-up. However, when one performs gross total resection, which is a major surgery with morbidity, the blood loss is higher. There are more surgical site risk of surgical site infection. In fact, one of our patients died because of an esophageal tear and mediastinitis. In 2012, when I met Dr. Stefano Boriani at a conference in Budapest, he suggested that for a slowly growing tumor like a hemangioma with limited recurrence potential, a gross total surgical resection was an overkill. This made us think on our strategy, and from then on, we started performing surgery along with embolization, vertebroplasty. In case the patients had pathological fracture, we added posterior stabilization. Because we were not excising the entire tumor, post-operative radiation was mandatory. Why embolization? Embolization causes ischemic necrosis of the tumor and shrinks the tumor size. It reduces the intraoperative bleeding. Why vertebroplasty? Because it strengthens the vertebral body and relieves the pain because of microfractures. It kills the tumor cells and leads to intraregional thrombosis. It results in irreversible sclerosis of the hemangiomatous venous pool, and it reduces bleeding prior to decompression. When performing the surgery, the steps of the surgery include embolization, which is performed 1 day prior to the surgery. At surgery, having exposed the surgical site, a vertebroplasty is done before any decompression is attempted. The vertebroplasty is performed such that maximum filling of the vertebral body is achieved. Following this, posterior stabilization is performed, and then finally a decompressive laminectomy is attained. Transpedicular decompression was found to be unnecessary because once the embolization and the vertebroplasty is done, majority of the vascular channels seem to close down, and there was very little tissue that was then causing a cord compression. Here is an example of a 48-year-old lady who presented with spastic paraparesis. She had a pathological fracture and epidural spread of the tumor. She underwent a pre-op embolization followed by vertebroplasty, stabilization, and laminectomy. Between 2002 and 2018, we have operated on 15 patients with asymptomatic vertebral hemangiomas causing neurologic deficit. 14 of the 15 patients had significant neurological improvement on follow-up of 24 months. Most patients reported a significant improvement in back pain, and none of the patients had a local recurrence at 24 months. To conclude, when vertebral hemangiomas present to you, one tries to see, is this a non-aggressive or an aggressive tumor? If it's a non-aggressive tumor and non-painful, no treatment is required. If it's a non-aggressive treatment but painful, one can think either of medical treatment or vertebroplasty and occasionally radiation. If it's an aggressive tumor which is contained within the vertebra, then one can think of doing only a vertebroplasty and followed by radiation. However, if there is an epidural spread of the tumor, one would prefer to do embolization followed by vertebroplasty, then decompression and stabilization if necessary, followed by radiation 3 weeks down the line. Low-dose radiotherapy is always given to tumors when gross total resection is not done. Thank you. Yes, yes, Marcelo.
Thanks for your talk, very comprehensive. And I have a very difficult case, so it makes, your talk was very useful for me. Let me ask you something. You make a very strong point about doing embolization always before your treatment. But in my experience, even though we have very good invasive radiologists, from time to time, they tell us, I'm sorry, I cannot move forward with embolization because there's a common pedicle with a cord supply. How will this issue change the way you approach this problem?
It's a very, very good question, Marcelo. As you saw in our cases also, there were 2 patients who could not be embolized adequately because of the same reason. And though these 2 were in the early phase of our study, when we used to do vertebrectomies for these patients. So in that case, we just proceeded with vertebrectomy. The question is, how would we proceed today if we were not able to embolize? But today, most of this is taken care of by if we are still not able to embolize, we are still doing a vertebroplasty, which kills a part of the tumor within the vertebra and shrinks the size of the tumor. And then we do only a laminectomy and we leave everything else to radiation to take care of. So I don't try to go. What I found when I was doing these vertebrae, which Dr. Boriani suggested to me, was that even in these aggressive hemangiomas, a majority, even when the tumor has extended into the spinal canal, a majority of the time the posterior vertebral wall was solid and intact. And if you wanted to remove it, you actually had to fracture it and punch it into the vertebral body. So therefore, the vertebral body is intact. It is the vascular tumor which has just come out from there. So we have been very safely doing vertebroplasty in these patients and stabilizing. So if your patient, their embolization is not possible, I would still suggest the same protocol along with radiation postoperatively.
Gautam, any special tip to do the vertebroplasty in this particular kind of lesions?
Any place of?
Any special tip?
Yes, so I always do a bipedicular vertebroplasty in these cases because I want to fill up the vertebral body as much as possible. So I try to do a bipedicular vertebroplasty in order to achieve as much fill of the canal as possible. The vertebroplasty is always done before we do the decompression procedure in these patients so that bleeding is less during the decompression procedure. And I try to fill up right from the superior end plate to the inferior end plate.
Thank you.
Dr. Gautam.
Yes.
Sir, Dr. Dave had a question in the chat box.
Yes.
So there's dead space created. How do you circumvent it?
No, that was for he had a question for the previous thing, and which was answered by Dr. Bernasconi. Here there is no dead space created. Here there is more space created, less space created. Don't worry. But in any case of recurrent hemangioma following, as I said, in my series, there were none of my patients had any recurrence at 2-year follow-up. I know that a couple of friends of mine from Bombay had patients who had recurrence when they had refused a radiation post-operatively after this kind of a limited surgery. And these patients had to be, again, one of them was tackled with a repeat vertebroplasty and then radiation. And another patient who was treated by somebody else underwent a corpectomy and fusion in this patient, anterior plus posterior.
So Dr. Menon wants to ask a question.
Yes, I think that will be the last question because we are running late. Yes, Dr. Menon.
Gautam, I have 2 very quick questions. One is, you mentioned that the posterior wall of the hemangioma is always intact.
Is usually intact. That's what my finding is.
If the posterior wall is not intact, what would you do? That's the first question. The second question I have is, what do you do in pregnant women? Because this is very frequent in pregnant women. I've had 3 cases so far, so I just have a doubt as to what to do.
So if the woman is pregnant and if you can treat it, the biggest problem in these patients is that if they are treated, they present with acute neurology, there is very little you can do. Every part of the procedure requires radiation. So whether it is embolization, whether it is vertebroplasty, then you are left with very little option but to think of a major surgery. I've had 2 patients, but both of them luckily had delivered and then came up with a vertebroplasty with the problem. So I haven't had that encounter as yet. Answering your first question, if the vertebral wall is not intact, what can you do? I think one patient very recently, what I did was I was still able to manage doing a vertebroplasty on one side. But in that patient, what I did was I first did the decompression and then did the vertebroplasty under observation. and still tried to fill the canal. And because I had kept the posterior wall, whatever was there intact, and gone down one pedicle to decompress, there was no leakage of the cement into the canal. I haven't encountered any serious problem, but I suppose if there is a significant posterior wall breach, then you would want to go and for an anterior plus posterior surgery and do a corpectomy with reconstruction. Would anything to add, Marcelo? You seem to be a little worried.
I'm fine.
Any other questions from anybody else?
Yes.
Gautam? There is a question.
Gautam?
Yes,
we chat box. A role of biopsy to confirm the diagnosis and the risks involved.
So that, as I mentioned, I think in my talk, that biopsy unfortunately is not very productive often, because the whole tumor is made of vascular channels. So when you go in there, you get a lot of blood, you don't get bone, or adequate biopsy is very common that you may not get an adequate biopsy. So that is there. And however, in the limited series of 15 patients, most of the patients are diagnosed based on the radiological picture. Literature says, however, that a CT-guided biopsy, if and when done, has not resulted in any significant complications or hemorrhage in these patients, in spite of the problem that one would think one would encounter. So yes, you could do a biopsy, but the chances that the biopsy will be successful in yielding a diagnosis are not very high. As I said, we are running very late. We have to move forward, and I request Dr. Marcelo to invite the next speaker.
Thanks. Well, for me, it's a real pleasure to introduce Gaston Camino. Gaston used to be our resident, I don't know, 10 years ago. Now he's in his way to be my boss. We started doing this procedure he's going to describe a couple of years ago. One of my partners, Carlos Solá, learned it from Peter Varga. But Gaston moved forward with this technique, giving really a scientific background. So he's the ideal person to talk about this procedure, Discoplasty. Gaston, are you ready?
Hello to everybody. My name is Gaston Camino Vilugar. I am from Argentina. I work at Hospital Italiano de Buenos Aires. And thank you very much to the Association of Spine Surgeons of India for this invitation. I am going to talk about percutaneous cement discoplasty, our institutional experience. These are my disclosures and conflict of interest. Before start talking about this procedure, I want to mention some changes that need to be understood, such as the intervertebral vacuum phenomenon. As is observed in these pictures, you can see that this space is start filling with vacuum phenomenon, which is the presence of gas or air within this space. This is a classic example of initial stage of vacuum phenomenon. We call it minimal vacuum phenomenon. Then in some cases, the vacuum phenomenon is more advanced to a stage that is called intermediate or partial vacuum phenomenon that can be present with or without subchondral sclerosis, as you can see in the right picture. And finally, in some cases, we observe like total intervertebral disc space covered by vacuum phenomenon. We call this a total vacuum phenomenon or more advanced stages. And this classification of intervertebral vacuum phenomenon was published by our institution, our group, last year. So what is known about percutaneous cement discoplasty? Well, this is an alternative to treat low back pain in elderly patients, especially in those patients which are frailty, in which conventional fusion techniques are probably risky, associated with higher risk of complications. And also this technique has shown to improve low back pain, at least in the middle term follow-up. These are the three main indications when considering this technique. At least in our institution, we consider the mechanical low back pain. We call it the pain that is increased by activity and a standing position and is partially relieved by resting position. Another indication is the presence of vacuum phenomenon, especially the partial and the total vacuum phenomenon are considered for us as a clue when treating these patients. And the accordion phenomenon is the change in the scoliotic curve. When you compare it, the standing position, as you can see in the left image, and the horizontal position, the CT scan. If there is a change in the angulation, we call it accordion phenomenon. We also consider this as an indication for percutaneous cement discoplasty. This is the technical procedure. We put the patient in a prone position and we insufflate her roll below the knees in order to produce an hyperextension and increase the lumbar lordosis, as you can see in the picture. After that, we use an extrapedicular access, mainly through the triangle, the camping triangle, and we access to in the corner, in the superior and lateral corner of the pedicle, and we use neuromonitoring in order to at least prevent or avoid nerve root irritation when inserting the cannula. You can see in the pictures how the cannula is placed and how the cement start filling the gap, the vacuum space. This is a case in which you can see the partial improvement of scoliosis from 25 degrees to 11 degrees, and also the improvement of lumbar lordosis. We believe that this is because the hyperextension in the position, as I mentioned before. So radiological parameters are improved, at least partially. The most important is the improvement of clinical parameters as well. This is a case, an 82 years old male with a severe scoliosis and spinal imbalance, and you can see, and cardiac disease. This patient is not a candidate for a fusion traditional technique because I can guarantee that this patient is going to suffer some mechanical complications secondary to a fusion surgery, you know, besides some clinical complications. And we believe this is a classic candidate for a percutaneous discoplasty, in which our goal is to partially relieve the patient's pain. But to be honest, we don't expect to improve all the pain. In this case, the patient has a low back pain in a rate of 10, 7 out of 10. And as you see in the picture, we use the percutaneous discoplasty and fill four these spaces. And you see in the postoperative control how the radiological parameters were improved, and partially. And the most important, the back pain was improved from 7 to 3 at 1 year follow-up. So we believe that for this patient, the technique was really successful. However, what is not known about percutaneous cement discoplasty? Well, this is very important because we need to understand the limitations of this technique. We lack of long-term outcome studies. The real mechanism of pain reduction is not completely understood. We believe that this is because the spacer function within this space, and we don't have level 1 or level 2 evidence studies about this treatment. So this is mandatory. We need to have better quality studies about this. But this is the current evidence that we have. From Vargas group from Hungary, they published the technique, and also they showed improvement of radiological parameters, and they showed the indirect foraminal decompression due to the stabilization technique. So they consider that this technique is also can improve the radicular pain, not just the low back pain. Then another group from Japan published the technique is similar, but they access to this space through a pedicular entry point. We use the pedicular entry point in L5S1 level, at the lumbosacral level, and they show improvement in in back pain and clinical parameters such as the OS3 at 2-year follow-up. This is our experience. We first published the technique with some variations from the original one, which is mainly based on the changes in the hyperextension of the lower limb in order to improve the lumbar lordosis, and also the use of neuromonitoring, which is still under debate, but is in order to decrease the rate of neurological complications associated to the introduction of the cannula. And we published a case series analysis with 54 patients with 1-year follow-up, an average 1-year follow-up. And we observed a pain reduction of almost 50%, and an improvement of the OS3 disability index as well. And then we published the classification of vacuum phenomenon, pointing out that the main indications should be at least a partial vacuum phenomenon, and the best indication should be a total vacuum phenomenon, because the spacer function is going to be more visible when the disc space is totally degenerated. You know, with the more vacuum you have, the better feeling within the disc space. As a summary, percutaneous cement discoplasty could be considered as an alternative when treating low back pain in elderly patients, especially in cases in which traditional fusion techniques can be associated with risks of surgical complications and clinical complications. And we have shown an overall 50% of pain improvement. So this is a satisfactory outcome for us. For sure, we need future directions, probably technically related, to improve the intervertebral spacer, maybe not cement, maybe more elasticity or elastic substance. We don't know yet. And of course, we need a better knowledge about which patients will be benefit from this technique. And so improve the indications and longer follow-up studies, and in addition to higher quality studies, in order to understand the real benefit and pros and cons about this percutaneous technique. So thank you very much for this presentation. I hope you understand the technique and can use it in the future. Thank you very much.
Thank you, Dr. Camino, for an excellent presentation of this new technique of discoplasty for degenerative discs in elderly patients. The questions, the talk is open to the house. Any questions from the audience or from the panelists?
Sir, Dr. Bharat Dave has a question.
Yeah, Dr. Dave, please ask.
Choice of access, left or right?
For what?
So the discoplasty.
Would you access from the left or right, Dr. Camino?
It depends on the patient's X-ray. We usually try to go from the convex side in an scoliotic curve, but you have to see when the patient is put on the prone position. The more interpedicular space you have between the two pedicles, is better to avoid, especially to avoid the nerve root, to avoid the injury to the nerve root, right?
Another question is, how do you control the cement leakage in these patients? Because one would expect annular tears in these kind of degenerate discs.
Well, this is a really important question, because we have observed some leakage in cases in which patients were operated with a microdiscectomy or an annular tear in the disc space. So we have to be very careful in those cases. But we usually prepare and mix the cement and wait at least 4 or 5 minutes before starting to introduce through the cannula, in order to avoid to insert the cement too liquid. We try to make it not too liquid, you know.
Another question, Dr. Camino, from the delegates is any incidence of late breakage, fracture of the cement and displacement into the canal?
We observed, so we had some cases with the cement leakage in the canal. Most of them were asymptomatic for sure, but we had some nerve injury due to the cement as well into the pedicle and things like that. So it's very important to be careful when inserting when preparing the cement and during those 5 or 6 minutes in which you wait to the cement to be more solid.
Right, a final question from Dr. Bernasconi, and then we move on to the next session.
Yes, a very good presentation. Congratulations. I have 2 questions. The first is that if you're taking care of the joints, do you do any block test before do it, the cementoplasty? And then if you're taking care, but you already mentioned now, the spinal canal after the procedure to try to measure the indirect decompression. That's what the real question.
Thank you very much, Dr. Bernasconi. Well, the second question, we didn't measure the spinal canal or didn't consider it, as the change in the lumbar lordosis is small, is probably between 5 and 10 degrees. Is an important question, and we should consider it in the future probably. And the first question, can you repeat it, please?
It's about the facet joint, because you're taking care the back.
Thank you. Yeah, no, we don't perform pre-operative block injection. We consider the mechanical back pain, and we hope these pains could be produced by this disc space.
Thank you very much, Dr. Camino. And with that, we come to an end. I hope that you've enjoyed this session. I think there was a lot of learning points in this session. And I would like to thank my co-moderator, Dr. Gruenberg, for this session, for joining me and helping me coordinate this session. I moved